Hey friends, I'm here with someone who's going to help us talk through in a really sensible way how to navigate some of the stress and anxiety and even practical problems we might have with our healthcare in the year 2026. I am here today with Steffanie Altenbern. She's a professor, social worker, therapist, popular contributor here on George Fox Talks for a reason. I heard you're working on a poverty experience, almost like a simulator, and we would have like senators and politicians actually experience in a room what it's like to have poverty so that they would know what they're dealing with when they make decisions.
Yes, that is actually the dream.
That's amazing.
Have representatives and senators. I don't really know if we'll get to that point, but I'm going to claim it. But
that's the dream. That's the idea.
That's the dream.
That's actually just that, though, as a thought experiment. That's a pretty cool idea.
Because those of us that, not necessarily just social workers, but us community-based folks or anybody that's volunteered.
Churches, soup kitchens, just living life.
Thank you. Any of that.
Yeah.
We see the day in and the day out struggles that people in poverty face. But the people that really actually need to understand or even get a glimpse of these struggles are the people that are making policies that directly impact.
Yeah.
So when we say there's a 20% or 26% budget cut in Medicaid funds in the state of Oregon, let's talk about what this looks like. Where are we overspending? Where do we need to dump in more resources based on what they're experiencing? And so what this does is it essentially gives people an hour of their life, and it's a training, and we'll have CEUs available for all of it.
Yeah.
But it's like an hour of their life, and they get assigned this identity. And these are based on real client stories.
Wow.
And they, confidentiality, all of that. But they'll have to go pay their rent, or they'll have to go pick up their kid from school. And in the meantime, then maybe ICE is showing up, or maybe they're getting an eviction notice, or maybe when they show up to pay their rent, the landlord has said, sorry, we're closed today, or we only take money orders from the Safeway over on 193rd. This is a money order from Fred Meyer, we're not taking it. This is wet, we're not taking it.
Yeah.
And so all of these things that can happen to people in poverty, it's taxing. For those people who have like successfully moved out of poverty and they're not living that lifestyle anymore,
right?
Kudos to them.
Yeah.
It's pretty impressive. So
how would you characterize our current healthcare moment in the United States right now?
Atrocious. Yeah.
Why? What do you mean?
My scope is largely limited to A, my own experiences, and B, working with those in Medicaid.
Yeah.
And I would say here in Oregon especially, our Medicaid system is like top 5 in the country, most expensive, most robust, progressive Medicaid systems. And so the cuts that we have been facing, pretty significant to really vulnerable populations. I also strongly believe in accountability too. And so as a provider, I've had many, many questions for how money is being spent when we see cuts in areas that I think are a little silly.
Yeah.
Yet, for example, like I have clients that they could come for a session every single day. And to me, that's almost like, that's a lot. But on my own private insurance, if I want mental health therapy every day, that's not allowed. And I mean, I can pay out of pocket. But so there are just some areas that need cleaning up if we're going to balance accountability with how public money actually is.
Yeah.
But then on the other side of that, on my own experiences and what I've needed to use healthcare for, it's an absolute maze.
That's what I was going to say, just from a human perspective. My experience, and maybe I just think of myself this way, but I think like, I'm not dumb. I know how to call somebody. I know how to think about words and things and talk to people. And for the life of me, I don't even know how my own healthcare works. In fact, I wanted to play for you. I don't know if you've heard this yet. I wanted to play for you a clip. It's a viral clip, so we can play it here on the show and we comment on it. And this is from a comedian's Instagram. We'll put a link down below that I think touches a nerve about this. So we'll play this clip for you.
When the Luigi Mangione thing went down, my Canadian friends were like, oh my God, like what is going on with the healthcare system? Like how crazy is it actually down there that something like that would happen? I was like, well, it's not that crazy. You just have to know the difference between your copay and your coinsurance and your deductible and your out-of-pocket max, right? And your deductible is what you have to pay with cash before your insurance kicks in, and then that's when you pay a percentage of that, which is your coinsurance, until you hit your out-of-pocket maximum. Which is technically the maximum amount of money that you'd ever have to pay in a given year, but it's actually not, because you're also paying monthly premiums similar to car insurance, right? And sometimes your employer will cover a percentage of those, but it's only a percentage, it's not the whole thing, right? And then you're thinking, okay, well then like what happens with my family? And that's a really good question. If you have a family, it's a new deductible and a new out-of-pocket maximum. You have to recalculate all that math until you figure out how much it's actually going to cost you in a year, and it's really hard to budget for that. But the IRS is like, don't worry guys, I got you. We have something called an HSA. And that's something where you can put, it's a health savings account. That's where you can put pre-tax money into a health savings account that you can then pay for your copay and your coinsurance and your deductible and your out-of-pocket max, right? And it's like you get it at a discount because it's pre-tax dollars, right? You can only get that if you have a high deductible plan. And if you don't have a high deductible plan, you can only do it with a federal savings account, which is similar to the HSA, right? Where you put pre-tax money into a bank account and then you can pay for the co-pays and the coinsurance. The funny thing about that is that it disappears if you don't use it in the given calendar year.
So why is that funny? Why do you think that resonates with people? Why have like 7 million people viewed that on Instagram Reels?
Yeah, that's a lot of views.
Yeah.
All the rules. There's so many rules. So many rules. How does one possibly understand that? Mm-hmm. I think I even need to add on to her too, another rule.
Yeah.
I had a recent experience in my family. I had to call the ambulance. We live 6 minutes away from a major hospital system.
Okay.
The ambulance gets there. Everybody's, of course, traumatized. The ambulance says, where do you want us to go? And I say, obviously.
They ask you where you want to go?
Well,
I'd be like, you tell me. I don't know.
Right. Well, you pick. The ambulance company asked you what hospital. Because like if you have Kaiser, everybody knows you can only go to Kaiser. Well, okay. I mean, that's a rule. Maybe you don't know that.
Okay.
So they say, where do you want to go?
See, to me, the bit gets funnier. I'd be like, I'm in an emergency.
Yes.
I don't know. Take me to where you think I should go. I clearly don't know how ambulances work. See,
well, you're going to learn. So I say, obviously, this hospital is 6 minutes from my house. Take them there. Great. We go, blah, blah, blah. Fast forward, we get the ambulance bill. Mm-hmm. I call and I say, well, this ambulance bill, we've already met our deductible. Yeah. Which is one of her rules.
Right.
We don't need to pay this.
Right.
And they say, oh, no. The ambulance isn't in network or out of network. It's its own thing.
You just pay.
They're a private company. They charge $47 a mile.
Okay.
The ambulance bill for 3 miles was $878.
Wait. That math doesn't even make sense.
It doesn't even math. So then I get the bill from the hospital and they say, oh, we're actually not in network with your insurance company. So this is all out of pocket.
And you were supposed to know that in the moment of an ambulance call.
That's what I asked. I asked the insurance company, I said, how would one know this? And they said, well, we recommend researching what's in network with your insurance. I'm like, no, I now know this for the next time my family's in an emergency. Yeah. Which is going to be when the deductible starts over. There's just so many rules. How could one possibly understand all these rules unless you've had to learn the hard way? Right. And pay potentially thousands of dollars out of pocket.
Yeah. I guess it taps into my own kind of feeling. And maybe it's just a feeling of despair. And as a person of faith, I'm not supposed to succumb to despair, but sometimes I do politically and even with things like this. I just think the world has become too complicated for normal people to actually navigate it. And it's almost like you can't make right decisions in a world in which you don't even know what you're saying.
Well, and anymore, those decisions are just becoming more and more expensive if you make the wrong decision.
Right. I mean, people have seen stats like this repeatedly. I just saw one from our government, essentially the Treasury or something, saying that some huge percentage of Americans, like 40% of Americans, are $400 away from needing to go into debt to pay for something. So in other words, if I was part of this 40% of America, if I had a $400 unexpected bill, you described an $800 unexpected bill, I would need to put that on a credit card and try to come up with the money somewhere else, not from my bank account. So the richest nation on earth. I mean, it's very confusing.
It's so confusing.
We live in this place of total paradoxes and confusions.
They actually did pass legislation. I don't know if it was state or federal legislation within the past couple years that said medical debt cannot be counted towards you in collections.
Oh, really?
And so to me, that just shows a number of Americans who have had.
Right. That it rose to that level that we had to make a law.
Yeah, there's a reason that happened.
I wanted to ask you, as somebody who works with the healthcare system, who advocates for clients in social work and therapy settings, I wanted to ask you about some of the big the big healthcare in the US storylines in 2026. I've done some research, done some clicking around. I'm not a healthcare expert, but I know that you have some traction on these things. And I think it'd be interesting for listeners just to think through, okay, I'm facing a world like this, and everyone has a body, and everyone has health, and everyone has family. And everyone might have to call an ambulance. And so I think these kinds of things are really relevant for us to think about, not to get whipped up into just anger or anxiety, but to think these are the examples that people are actually facing. So let me take these one at a time. I have several of them, but if you're up for it, I'll just list them.
Yeah.
The first one, I heard this called uncompensated care crisis. So during COVID, we had all these like tax benefits and things that were just going on, like, hey, we need to take care of people. But these things are now expiring. There are new work requirements for some people, like on Medicaid, for example. Might mean that close to 5 million people are going to lose care. In other words, which thrusts therapists and social workers and moms and dads and grandparents into positions, and even people themselves, to have to like advocate for people to navigate the loss of care. And by the way, we'll have links to all these things down below if people want to take a deep dive. I'm not just pulling these off the internet in random places, but like, have you seen this uncompensated crisis and having to advocate and just to navigate the system? Is this a big deal? Do you see this happening?
I do. I use the term, I describe myself as being a therapist very loosely because a lot of what I do is help advocate for people navigating the healthcare system. We have a client right now, not from the US, and we have spent probably 23 hours trying to help him get a prescription that will keep him from having a heart attack again. And we're going, and it's Medicaid dollars that are being used for this, and nobody's willing to take the time or understand. They just keep sending this client letters in English saying, this is what you need to do. This is where you need to go. You get there. Oh, you have to go to this office. Oh, you have to go to this office. And for us who our agency's pretty seasoned with these systems, we're more focused on helping people advocate and educating them and learning the system. Whereas a lot of traditional mental health therapists, you show up for your 1 hour, you talk about your childhood traumas, whatever it is, and you go about, and then you're just expected to know what to do. There aren't enough people, as that clip showed, we have to understand how to navigate this system. And that is taking a pretty specific targeted group of people to say, we're not going to do therapy. We're not going to do this. We just basically exist to help you understand how to navigate. And to me, it's sad that I even have a job doing that because it shouldn't be that complicated.
Sure.
We should have our insurance people explaining that, or we should have our doctors or whoever explaining that.
I don't even think the problem, by the way, I could just to advocate for anyone who might be listening to this. I know we're in the middle of this big immigration crisis discussion. And even if one took the position that like, well, we shouldn't even be trying to do healthcare at all for people who aren't from this country. Okay, let's say that that's even a position that one had or said that was debatable. It still costs money when people go to an emergency room, when they're sending these letters. Yeah. I mean, it's like we're still responsible as a nation for the situation that we're in. And so even if you were just focused on money and efficiency and rules, this still has to be, we still have to deal with this somehow. Yeah. Right?
Yeah, we do. And I even find with my clients too, regardless of their citizenship status, if it's just you or I or somebody who isn't from there, the hospital systems are getting overwhelmed with this too. We take somebody into the ER for a true, like we had a client with sepsis. That's something, if you don't know much about that, like that's deadly. Like that's not good news. And just the way they were treated at the ER, just because I think largely they were so burnt out from seeing the Medicaid revolving door. Oh, you can't get access to housing, so you're back here. No, this person is actually really sick. You need to admit them. This isn't like I have a splinter. This is a big deal. And I think systems are just overwhelmed. Yeah. The compassion is dying out in a lot of ways.
Okay, let's go down this trail of misery further. I'm realizing this is a trail of there's a lot of misery here. It's tough. I gotta laugh so I do not cry. Second category, healthcare anxiety. People are now reporting that their anxiety over the cost and access to healthcare is actually outranking the cost of food and even housing as their top concern in life. And there's this idea that probably people in social work and therapy have been familiar with for a long time, the idea of rationing, like, oh, I'm going to buy food for my kids, but I'm not going to eat, or I'm going to pay my rent this month, but not my utilities. And so now healthcare is coming into this. I've got a study from the Kaiser Family Foundation in which this polling is there. Do you see this actually popping up? Are you surprised that now healthcare is showing up as by even a significant margin in the poll, I saw the number one actual anxiety concern in people's lives.
I am definitely surprised in a place like Oregon because it's always been a pretty progressive state. I've lived in fairly rural states, Wyoming, Idaho, and what we're seeing now in Oregon is what a lot of red states have faced many years ago. For example, when we didn't have the Medicaid expansion, I had many of my own colleagues who run private practices. They didn't make enough to make Medicaid, and the healthcare premiums were so high. And now Oregon is starting to see that. And yeah, we have folks that are having to shut down their private practices to go get jobs because the healthcare is astronomical. I mean, you're talking one person a month for a high deductible plan and $900 to $950 a month for high deductible healthcare coverage. I mean, that's a lot.
So in other words, people who maybe would have to have small businesses and provide their own, they're like, I got to go work somewhere, anywhere that provides health coverage because this doesn't work.
People are having to make really hard decisions with that. And I don't see that getting any better for the businesses that don't have to shut down, that have to provide healthcare to their employees because those costs are also going up as well, which then it's a domino effect, right? Because maybe the healthcare plan is going to have to change. So at open enrollment, you used to have this plan, but now this plan's the only option. It's $300 more. It's kind of crappy coverage.
Yeah.
And so then that might lead to potential bills for a family that has to use it. And the high deductible plans, I mean, there's several thousands of dollars before insurance kicks in.
Yeah.
So it's not, I'm not surprised that we're going to seeing it, but it's a sad reality for where we're at.
Yeah. What about this one? Rural care deserts. You just talked about living in places like Idaho and Wyoming. I just assume that they're large swaths of beautiful land, but not land with big cities and lots of stuff. So in other words, swaths of geography where there are just no specialists. It might be that there's a hospital or that there are doctors, but there aren't certain kinds of specialists. Maybe you have to wait like 14 months to have an appointment with a physical therapist, or 9 months to have an appointment with a dermatologist, or like something like that, just to get basic care. How big of a problem is this actually?
I think it's a big problem in rural, but I think that is a huge problem in the cities too.
Oh.
I think this topic actually does fire me up a little bit because I think there are a lot of people, a lot of specialists, a lot of even primary care providers, a lot of providers in general that are willing to work in rural areas. I think where the shortage comes in is people willing to accept certain kinds of insurances. I know many providers who have gone just away from insurances into a cash pay model.
Why would providers get intense about which insurances they accept in general in healthcare and in mental health care practices generally? What's the...
Because the red tape is excruciating.
So they're not all the same. Some of them are easier to work with. Some of them are harder. Some of them probably can, I guess, pay more and less, and sometimes that's an incentive or not.
That is absolutely an incentive. In most states, Medicaid and Medicare pay the lowest. And so you have a hard time with providers that are willing to jump through that red tape for, you just paid me $37 or whatever the state pays for this visit, which Medicaid clients or patients can tend to be pretty high need. So there's a lot of care management that goes in with that. And they're not willing to do it.
So if you're a provider and you're kind of scanning, like, should I take this insurance? Should I take that one? You look at Medicaid and you're like, a shiver goes down your spine.
Yeah, not necessarily in Oregon. In Oregon, for behavioral health, at least, I can't speak for physical health. Behavioral health, Medicaid actually pays higher than private insurances, your Providence, your Blue Cross. In some situations, it pays almost double.
Yeah.
Which is huge. It's unheard of. And if our agency existed in a place like Idaho, I mean, what we bring in per hour per client, it would be like a fifth of that. We wouldn't be able to exist. But they come with a lot of red tape. We got audited on a particular client and had to pay back half that amount.
I've heard about these clawbacks that they
It's insane. It's insane. There's legislation right now, and it's been going on for years. Providers want to say, they're saying, let us do our job. You can only audit us back 12 months ago.
I see.
But insurance companies are saying we can actually go back 6 years because there's federal legislation that allows us to do that.
This is not like this is not a business model. I mean, I know people might be like, I don't know a business or practice. How is this relevant to me? I mean, but a lot of us use these kind of practices, mental health, doctors certainly. So I think it's worthwhile to just like stop and reverse engineer this and think about the structure that we're in and just like the kinds of concerns. So this is the kind of business where it's not like selling watches or audiovisual equipment where you could at least say, fine, if you're going to take this back, give me the stuff back. there's nothing to give back. You already spent all that time. That's gone.
And then not to mention, let's say you are a patient, you go to access your PCP and it's a certain insurance, and then the provider sends off to the insurance company, okay, we saw you, Brian Doak, for this mental health, behavioral health visit. We're submitting to your insurance. You then get this piece of mail that says, oh, this was actually denied for this. Pick the reason out of the sky. It was any reason that was really silly.
Sure.
The provider now has to spend time. If I'm your provider, I have to call and I say, help me understand why you denied the claim for Brian Doak. Oh, that was a mistake on our end. We'll push that back through.
Okay.
And I mean, I've got a list of 75 claims in our agency that I've been calling on. And for one claim to get resolved, it was 39 minutes.
Yeah, I mean, and for people who work with small businesses, it's not like, hey, I'm working for my company and they're paying me while I sit here and I'm playing a game online while I got my earbuds in. It's like, that's actually time that you would be spending. And
providers aren't willing to do that. And so, they're going to go to practices that are willing to give them a good amount of support. Mm-hmm. And a lot of times again, I've heard from many providers, behavioral health or physical health, that it's just, they do cash pay.
Yeah. Okay, let's take our final stop on this bingo card of healthcare 2026 misery, Alorithm Bias. The idea that as AI and algorithms take over coverage decisions, they may disadvantage certain people. For example, one thing I read about, of many examples, there's an idea built in algorithms that those who spend less have fewer needs. So the way you allocate and make decisions, but they don't. It's people who spend less just don't have as much money to spend on the needs. So you'd think that would be something we could account for, but this is the way that data works, is just big categories and so on. Or also the problem of wealthy hospitals or communities are just able to leverage algorithms and AI in ways that are better. So it's not a new dynamic, it's just a new variation on the old dynamic, which is that people who have a lot of stuff just get better stuff. And people who don't have a lot of stuff get worse stuff by comparison.
I think that AI data exposes a lot that we didn't know. I mean, I think when I think about AI in healthcare, I don't think about showing the inequities. I think about how it can make providers' lives easier. And in a lot of ways it has. We can actually have AI listen to the visit so it can do the note for us so it's medically compliant and hopefully insurance stays off our back. But what some of this data has shown is even like medical equipment, like a pulse ox, it measures your oxygen levels.
Right.
Those are really designed for light skin to get accurate readings. So if we have people that don't have light skin, AI is showing us that those readings actually aren't accurate. Now, what are medical equipment companies going to do with that? Are they going to take that and are they going to use that to improve? We'd like to think so, because that's what the data has shown.
Right.
That's where the problem is.
Yeah.
But are they actually going to do anything with it?
Yeah, every tool is tested and keyed into somebody's body that they developed it on, and people's bodies are largely the same from a big perspective, but also different.
There's definitely some different nuances
lots of
with that.
serious ways.
Yeah.
There are two more topics I want to talk about, and I want to end just as a teaser by I want to just whet the appetite here. I want to ask, what is a normal person supposed to do who's just worried about this to navigate all of this better this year? But I want to also ask this question, which is just so near to our hearts and near to the heart of this podcast, which deals in the integration of Christian faith with every area of life. I want to turn to Christian faith, even to Scripture, and just ask, whose responsibility is it to fix this? And I know that that's a question that we can't solve. We can't fix that. We can't all get all into this. We can't get, we literally, viewer, we don't know. But listener, we do not know. But I guess maybe I could make the question a little sharper and say, or a little more narrow and say, what should caring Christians do? Is biblical advice even practical? I pulled two verses from the book of James, which actually addresses healthcare topics in a way sometimes.
Definitely.
Not the only place, but just these two I want to read. James 1:27. The author there, James, says, "Religion that God our Father accepts as pure and faultless is this, to look after orphans and widows in their distress and to keep oneself from being polluted by the world." So a big category there. But then also James 5:14, "Is anyone among you sick? Let them call the elders of the church to pray over them and anoint them with oil in the name of the Lord." And I read that and I find both of those verses very beautiful. Maybe you do too, and you could reflect on them. But I also think, how do we make this relevant for our actual lives? What do you think?
Yeah, one of the social workers that works in our agency, we ask ourselves and each other this question every day, whose responsibility is this. We have all of these folks in our agency work specifically with the medically vulnerable population. And when we run out of answers, we lose a lot of hope for these folks. They don't have any community. They have nobody.
Yeah.
Whose responsibility is it? Because them just living just with such a poor quality of life, it's just, it really, really, it feels crummy.
Yeah.
And we a lot of times want to look to the church to say, how can the church help support this?
Oh.
And a lot of times it's like, okay, well, if you're not a member here, you can't get access to our benevolence funds and you're relying on things like Portland Street Outreach. And so I don't know.
Yeah.
But it's definitely a question that I think if we just look at our own individual behaviors and how we can help contribute. And for me, this work it's very missional. It's very much a calling. I love doing it.
Totally. I mean, you'd have to, otherwise you wouldn't be able to do
No,
it. You'd have to
right.
rely on a verse like James 1:27.
Yes.
This religion, sometimes people don't like the word religion, but like this idea of some organized system of like worshiping God, that acceptable worship is looking after orphans and widows, and which is just a biblical category, probably for all kinds of people, who would be the kinds of people that care providers would encounter every day.
But I think what we can do is we can at least understand the system, if not for our own health insurance. Like, hey, if you have to call an ambulance in the middle of the night for your kid, which hospital are you going to go to? Because some of them might be in network.
Okay, what about that? What about this right here? Is anyone among you sick? Let them call the elders of the church to anoint them with oil. Christians belong to all these different traditions. I wonder, I don't know, if it's worth thinking about the way that sometimes even maybe we encounter people in your line of work, encounter people who are just really like deep believers in the power of like healing or prayer. And they want this to be integrated in some ways. And maybe some providers aren't really able to handle that. I'm sure for very secular people seeking therapy or care, to have a faith provider who's recommending prayer with oil might not be something that they would accept. But in some cases, for you to have some kind of connection to that faith network, it might resonate with a lot of people.
It is true. And along those lines of, not necessarily just oils, but I think people in general are they're very open to different ways of healing. I mean, the internet is full with Epsom soap.
The internet,
salt.
you say? You could just Google things and get all kinds of...
Dr. Google. I mean, if your elbow hurts, Dr. Google's probably like, you might have
try this
elbow
internet
cancer.
you speak of for some problems.
But I think people are open, and I think they're hungry to different ways of healing.
Yeah.
Either A, because they don't want to go through their medical system and they can't get an appointment for 15 months like you had mentioned, or B, the 7 minutes that they're getting with their provider just isn't cutting it.
Yeah.
Or the side effects of meds. I mean, the list can go on, but people are definitely open to learning more about what can be done.
That's one of my most nervous moments, just personally sharing, when I'm in that doctor's office wearing the little robe or something, depending on what they've got you doing. I'm like, it's that moment, I feel anxiety actually. It's that moment when they're going to come in, they're going to say, hey, I'm so-and-so. You say, hey, and they say, hey, what's going on today? And you're like, how am I going to say this in a way that actually makes sense? And I end up rambling and I don't get to the point, or I'm afraid because they have so little time to actually make a decision. And I'm afraid I'm going to cue them in the wrong way or something, or they're not going to understand. That's probably a deeper personal problem I have for not being understood. But like, I wonder, you've already mentioned this issue of maybe even average people who might even undergo a situation like yours should maybe just think a little bit and put a little note card on your fridge being like, if we had an ambulance come, here are some emergency rooms or hospitals, I don't know how it works, that are in network where I would actually tell an ambulance to take somebody. Is that a practical thing someone could do? And if so, tell me. And also, what else? I mean, what are things average people can do to just have a better 2026 on the healthcare front?
I think it's actually knowing who your PCP doctor is. Many of us, I don't know about you, myself, my health insurance, they designate this provider.
I sort of know for myself.
Sort
of.
And it's
I'm close to knowing.
Okay. And it's like my person's name I can't even pronounce. I think I literally saw them 3 years ago for one thing, and that was it.
Okay.
And if I have medical needs, I'm pretty fortunate. My husband's he's a physician, and so I have this direct access, and that's great. But before that, I was like, if there's a situation that comes up, I'm probably just going to have to go to the Zoom care, the urgent care, which is going to cost me more. But because I don't even have a relationship with this guy. And at the Zoom care, I've always had good luck.
I see.
And I just had a recent situation where that's what it was. I had this crazy rash, went in to get some labs, and the rash ended up all over. And I just had to go to the Zoom care just because the PCP was like, oh, I can't see you until next Thursday at 3
you're
p.m.
I'm dying. I'm going crazy with this rash right now.
Yeah,
I
and
need to hold it up to the screen.
And it turns out, you go into the Zoom care and they run labs and they get them there on instant and they say, you need to go to the ER. And I'm like, well, I'm glad I didn't wait for the Thursday at 3 p.m. appointment And so knowing who you can go to in a moment, whether that's in network or out of network, because when you have an emergency like that, cost doesn't always matter in that moment. It does later, but it's an emergency.
Right.
And finding and interviewing multiple PCPs. I mean, there are people out there who they will give you more than 7 minutes. You just have to find them. Because there are good physicians out there that really, really do care.
So maybe organizing some info. I mean, these are things that too, I think for somebody who hasn't even taken these steps and just sees even their own healthcare that they're paying for as this opaque thing, to even just have a note card like, here's the name of my current PCP my primary care provider that I can't even remember on a card, and I could actually look at that. And also just knowing a couple of these places where one could go.
Yeah.
Yeah.
That's close to your house.
Yeah.
And somebody that will answer their phone. For me, the larger systems are overwhelming. I want the smaller clinics that they're going to answer and I don't have to press 8 prompts and have the hold music. Like I want somebody that's going to answer the phone right away. But
final question, just kind of for fun. 2026, you're looking at the year ahead of you. What are you going to do to take care of yourself physically this year?
Walking in nature. 5 days a week, whether it's 15 minutes, an hour, getting outside.
Yeah. We should all do that. Thanks so much, Steffanie, for this time.
Thanks.
Yeah.